Thank you, Tor. It's a real honor to be here with you. And there is no doubt that we have seen excellent information related to echocardiography. Echo, 3D echo, allows you to really analyze what is happening inside the heart and how is the systole and diastole in a much better comprehensive and accurate way. But what is CBI fusion? I think it's clear we need to know that when we merge, we obtain benefit from different techniques. So at the end of the day, the result is much better. So we merge here the results of the different cardiovascular imaging modalities into a single hybrid display. And what is here? Well, we merge 3D echo, and this is a prototype work in progress that we are developing in Madrid together with Toshiba in Japan. And the beauty is that we get the information from the 3D echo that allows obviously a complete view, a complete picture of the heart. The heart is a 3D structure. I want to see it on 3D. And I will analyze how it works and how it functions in 3D. So we get the benefit from analyzing the morphology, how it is, and how it works, how it functions. And the CT, we have now low radiation protocols, but really offer an accurate view of the coronary anatomy. And it is not possible with 3D echo. So we can see the beauty of assessing the morphology of the coronary arteries or veins, as you will see later, and assess what is all the information provided by 3D echo. So how we do that? Well, the first step is merging the coronary CT, as you can see here, with the 3D echo, with the information of the wall motion in the different perspectives, and the information with a different perspective of the coronary anatomy. So we need a CT scan and we need a 3D echo, and we merge the information combined by both. So let me summarize how are we doing that step by step. So first, we load the individual DICOM data sets from the CT and then from the ultrasound. There's no need to do that simultaneously. So we do it in the same day, trying to avoid any change in the pathology of the patient. Then we set the image display and we overlay the information from both techniques, and we match the axis of the CT and the ultrasound. So here we have a CT image. You can see the LV, the right ventricle, and in an automatic display, you can see this automatic axis from the apex to the mid portion of the mitral annulus. You can see that also in the four-chamber view. Well, now you need to set the rotation axis in the CT data. So here is the left ventricle, the right ventricle. You have your red, that was the longitudinal axis. But now you rotate the angle with this blue line, you do it manually, and you recognize any single marker that you believe it will be easy to match with the 3D echo. So for example, the juncture of the right ventricle to the left ventricle. And the same we do with the ultrasound data. So you can see here the axis from the apex to the mid portion of the mitral annulus, and same as we did with the CT scan, we can manually rotate to the same marker, here the left ventricle and the right ventricle, same marker that we use with the CT scan. So now you can really match and you overlap, you can manually control how is the image of the CT, and you can detect your markers, how is the image of the CT and with the echo. So at the end of the day, you are sure that both matches in an adequate way. Or if not, you can manually control and redo again the matching of both techniques. And what is the result? I think that what is the beauty of the result is you have the left ventricle, you can also see the aorta. I do believe that this will be also nice, for example, before TAVR. You can recognize the coronary arteries, where they are, what is the structure, what is the relation with the origin of the artery with the valve, and you can rotate and display the information from the left ventricle and the coronary arteries. And it is quite easy to obtain all this analysis. But moreover, now what we need to combine is the anatomical information with the functional information. So we can display, really, and we work with that, showing where the, not only the position, but also if you see a stenosis, and also what is the information coming from the functionality of the heart. So we can analyze in different perspectives the contraction and the relaxation, also in different modes. So we can see the 3D vectors, we can see the 3D mesh, or the donut view. So we can analyze, in fact, what is happening here in the different segments of the heart, and we can relate what is happening in the different segments with the relationship of the coronary arteries. Is it really relevant? I think it is. I think that for the first time we can combine the morphological impression, the morphological information that we have from the coronary arteries with the morphological information and functional information of the 3D echo. There is a case that we published last month in our journal, in the European Journal of Cardiovascular Imaging, and you can see that areas of ischemia can also be matched with the stenosis or with the different perspective and information from the coronary arteries. But not only that, I mean, we have seen two excellent lectures before mine, and you can see that it's quite important to analyze more than ejection fraction, and we can analyze the strain and get the information with the coronary arteries. We can analyze the torsion, and we can analyze, and I'm sure this will give us, and this is the next step that we are developing, we can analyze the activation imaging. Just imagine that instead of the coronary arteries, we can display the coronary veins, and maybe we can analyze before CRT where to place the lead if we have a proper vein according to the activation imaging, to the delayed segment. So all this information, I'm sure, that will give us clinical value. So clinical case, I mean, it's really relevant. Let me show you just one example. I know we are running late, but it is breast image, information of the coronary arteries, peak stress. You can see the area of ischemia related to exactly which branch has the severe stenosis, or in fact, it will help you to detect the culprit lesion. So all this information that we estimate with a stress echo, I mean, we say, well, this territory corresponds to LAD. Now you will say this territory corresponds to distal LAD or to this segment that has this specific severity of a coronary lesion. So I think that really we will manage better the risk. This is a patient that I have described with 3 vessel disease, and you can really depict where the ischemia is and where exactly you need to better treat the patient. So why? Why we need to do that? I think the answer is easy. We learned that in the stories when we were kids. I think that the combination is much better than being single alone. And I think that it will be much more easy to detect and to better assess certain pathologies in our patients. So in conclusion, I think that no doubt fusion CT and 3D echo is feasible. I mean, this futuristic approach is already here. The beauty is that we combine morphological information with functional information, and this combination is exactly what heart disease is all about. I mean, it's the beauty of taking the morphology of one technique and the functional information from other. And I think that it may help. We need for sure studies, hoping anyone wants to cooperate and start working with that, willing to do joint efforts together. This may help in some patients, like as I described, coronary artery disease is already giving us precious information. Sure that CRT may help in detecting exactly who are the non-responders. Just imagine delay segment but no vein. Where are you going to place the lead? If there is no vein there, no need to place the lead, you can't, and this will increase the number of non-responders. And assessing functional in stress echo, but because, as you know, coronary disease is not a morphology disease, it's a functional disease. So future research for sure should come to place this technology in the proper diagnostic place that is here. Thank you very much.